Good afternoon, everybody. Based on wherever you are in the world, I see people here from in the chat box telling that from Zambia, from New Mexico, from Tanzania. Thank you all for joining us. It is my great pleasure to introduce Dr. Stein. Dr. Stein has been an attending in ultrasound and body imaging at Montefiore Hospital since 1991. She is an alumna of Montefiore Medical Center and Albert Einstein College of Medicine, where she finished medical school and completed her residency in diagnostic radiology. She also holds a fellowship in body imaging at North Shore University Hospital and is a fellow of the American College of Radiology. As Director of Medical Student Education for Radiology at Albert Einstein College of Medicine, Dr. Stein developed the curriculum for the new clerkship at its inception. She is a superb teacher. She was awarded the prestigious Leo Davidoff Society Award for Outstanding Achievement in the Teaching of Medical Students in 2007. As a part of an excellent clinical team at Montefiore, Dr. Stein has particular expertise in abdominal, transplant, gynecologic, and obstetric ultrasound. Dr. Stein has contributed numerous publications to the radiologic literature and has served as a mentor for medical students, residents, and fellows in the radiologic research. Thank you, Dr. Stein, for giving us this opportunity and for your acceptance to give us this talk. Thank you.
My pleasure. Thank you, Mohammed, for that wonderful introduction. And I'm so glad to be here and speaking to you all from the Bronx in New York. I'll be talking about ultrasound of the acute scrotum. So what do I want you to learn? I want you to be able, by the end of this talk, to be able to list the causes of acute scrotal pain, to distinguish testicular torsion, which is a surgical emergency, from torsion of the appendages and epididymitis, and to avoid pitfalls in their diagnosis. Then we want to go into complications of infection, such as piocele, abscess, and testicular infarction. Of all these things, entities that I measured, the most common thing I see is infection, epididymitis, and orchitis. We also want you to be able to recognize appearances of scrotal trauma and be able to combine history, physical exam, and sonographic findings to establish the correct diagnosis in complex cases. History is key. Before I start looking at an exam, I always ask my tech, what side hurts? Let's go through some basic anatomy. So this is a longitudinal diagram of testicular anatomy. This is the testis, and these are the interlobular septa dividing the lobules, composed of these seminiferous tubules, which converge at the mediastinum testes, and then connect to the efferent ducts, and then to the epididymal head, body, and tail here, which connects to the vas. And okay, and this is the tunica albuginea. That's the fibrous coat that covers the testicle. Okay, and this is the transverse diagram of the testicular anatomy. Again, here's the testis divided into lobules containing the seminiferous tubules. And this is the tunica albuginea, which is the lining closest to the testicle. And then if you go more outer, you have the visceral layer of the tunica vaginalis and the parietal layer of the tunica vaginalis. It is between the parietal and visceral layer of the tunica vaginalis where hydrocele form. Okay. And this is the reedy testes where the tubules converge. Okay. The normal adult testes are ovoid and homogeneous and measure about 3 centimeters in anterior posterior dimension, 2 to 4 cm transverse and 3 to 5 cm in length, with a volume of about 13 to 19 ml. And remember, the size of the testes decreases with age, and the testes will also be smaller in children. So from the mediastinum testes, you have those radiating septa extending into the testes. So they're about 250 to 400 lobules. And each of these lobules contains 2 to 3 seminiferous tubules. The seminiferous tubules carry the sperm via the tubules into a dilated space within the mediastinum testes called the ready testes, and that drains into the epididymis through 10 to 15 efferent ductules. The efferent ductules in the head of the epididymis, also known as the globus major, unite to form a single duct, globus minor, in the epididymal body and tail, and which continues as the vas deferens. So what are the reedy testes? The reedy testes are an anastomosing network of tubules that carry the sperm located in the hilum of the testicle, called the mediastinum testi, that carries sperm from the seminiferous tubules. Reedy testes drains into the epididymis through about 10 to 15 efferent ductules. Now, how do we do ultrasound? We went through anatomy. Let's talk about how do we do ultrasound. We use what transducer do you want to use? You want to use a high frequency transducer of about 9 to 15 megahertz. Why? High frequency transducers have good resolution in the near field. They don't have depth perception, but we care more about resolution because the scrotum is a superficial structure. So that's key. High frequency transducers. The patient is supine. However, sometimes you have to turn them upright when looking for an inguinal hernia. When we look for hernias, we have the patient do a Valsalva and also stand upright. The scrotum is supported on a towel laid over the thighs. A clear gel is applied to the scrotal sac to help transmit the sound waves. Both the testes and epididymis should be evaluated and measured in both the longitudinal and short axis. This is the transverse axis, with and without color Doppler. So everything in ultrasound, besides testes, everything has to be in 2 views, longitudinal and transverse, to get a 3-dimensional picture in your mind of the structure. So not only do you do color Doppler of each testicle, you want to do spectral Doppler also, in which you see the waveforms. Sometimes I'll see on a testicle on color Doppler all this flow, but some of it's just artifact. That's why you want to see what it is with spectral Doppler. And as I said, for looking for hernias, stand the patient up and also have them do a Valsalva. So let's talk about color and spectral Doppler parameters. They should be set for low flow. Use a low wall filter and a low pulse repetition frequency. The power Doppler may be necessary to prove testicular torsion because power is very good for perfusion. Both a short axis and a color Doppler image should be obtained, in which both testes are imaged side by side to compare their relative size, relative echogenicity, and blood flow. So when my techs do an ultrasound, they start off transverse grayscale on the same image. Therefore, I can compare the right and left testes with grayscale. And the beauty of that is that I have the same technical parameters, same gain, same everything. So I can directly compare the echo texture. Then I put Doppler on, and I still compare the right and left on a transverse image with the same parameters. So that's my first and second image that the tech should provide. Some tips: use enough gel to eliminate gas trapped in the skin fold of the scrotum. Do not change the settings when moving from one testis to the other because you want to compare like to like. Now let's talk about ultrasound. This is a longitudinal image of the testis and epididymis. On a longitudinal image, this would be where the transducer is. That's called the transducer footprint. And you can see it's linear as we use a linear transducer. The orientation on a longitudinal image, this is anterior because that's where the transducer sits. Posterior is here, superior, inferior. So this is the testes. It should be soft tissue homogeneous. And this is the upper pole of the testis. And superior to the upper pole of the testes, we have the epididymal head, which should measure less than 12 millimeters anterior posterior dimension. And if we continue and follow that epididymal head, we go into the epididymal body, which should be less than about 5 millimeters. So again, here's the head superiorly, body, and the tail, which I don't see, which is usually a little nubbin, is inferior to the testicle. So this is the second image I like to see. The first image is the transverse grayscale, meaning no color. Then the second image is the transverse color. So I can compare the relative vascularity of the two testes. So again, this is a transverse view. So the orientation is anterior, because that's where the transducer sits. Posterior, right and left, just like a CAT scan. Here's our scale, which we want to keep low as we're dealing with low velocities. This is the scrotal wall. So this is two young men with right scrotal pain, patient 1 and patient 2. Both have a paucity of flow in the right testicle. Note flow on color Doppler in the left testes. So history is key. That's the point of this slide. Let's go to the two patients. This patient had pain on the right. He had flow in the left. This was testicular torsion, a surgical emergency. This patient has a big hypoechoic area in the testes. My technologist thought it was a torsion, and this is the normal left. We looked in the chart. His testes had just been removed for cancer, and this was a hematoma, which you'd expect to have no flow. So you need to know the history. So the differential of acute painful scrotum, the most common thing I see is epididymitis, and then I see torsion of the testes. I don't see torsion, thank God, that commonly. Maybe I see it more in younger men or kids, and this is a surgical emergency. Then torsion of the testicular appendage is treated with non-steroidal anti-inflammatory drugs. We'll talk about trauma, and the less common causes of acute painful scrotum include a strangulated hernia, edema, an acute hydrocele, Henoch-Schönlein purpura, and hemorrhage or infarction in a neoplasm, really rare. Main thing I see are the torsions and epididymitis. Now we're going to discuss torsion, intravaginal torsion. The normal situation, which is this, the visceral tunica covers the anterior and lateral aspect of the testes and attaches to the posterior lateral testes. The cord is adherent to this posterior scrotum, so the testicle is tacked down and cannot rotate, as opposed to the bell clapper deformity, which I'm showing you here. The visceral tunica encircles that testis, epididymis, and the cord, so the testis and cord can rotate, making you prone to torsion. So intravaginal torsion is the most common type we see. It occurs highest incidence in puberty in 65%, 12 to 18 years old. And that is associated with the bell clapper deformity. 40% is bilateral. That's why if the surgeon has to operate, they'll tack down both testes, if you could salvage the symptomatic one, because of the bilaterality. So that's intravaginal torsion. What's extravaginal torsion? The less common type of torsion. It occurs in newborns or in utero, and it's secondary to mobility of the entire tunica vaginalis. There's twisting of the testis, epididymis, and tunica vaginalis on the cord. And there is no bell clapper deformity. And this is rare, very rare. Torsion requires immediate surgery. That's why if I have a patient with a torsion, I will immediately pick up the phone and call the emergency room because time is of the essence. We can salvage 90% of testes if they operate within 6 hours. If they wait a little longer to 6 to 12 hours, the number goes down to 70%. And we salvage 20% if operated after 12 hours. So what are the ultrasound findings in acute torsion as defined as less than 24 hours? Well, the testes and epididymis on grayscale may be normal, maybe totally normal. You wouldn't be able to tell anything without Doppler. Sometimes the testes will be enlarged due to edema, heterogeneous, and hypoechoic. You'll have reactive skin thickening and reactive hydrocele usually. Hydrocele is nonspecific. You can see with torsion, infection, tumor, trauma. And what do you see on color Doppler with acute torsion? Absence of blood flow if the torsion is more than 540 degrees. So it has to be, this is what a complete twist is. What is a subacute torsion as defined as 1 to 10 days and chronic torsion greater than 10 days? A subacute, the testes can be normal or enlarged and heterogeneous. By the time the torsion is chronic, the testes is small and atrophied and heterogeneous. You will have absent intratesticular flow, and you might have hyperemia in the peritesticular tissues, mainly in subacute torsion. Some examples. This patient had left testicular pain. This is a longitudinal grayscale image, which looks totally normal of the testicle. You put on color Doppler, you see flow in the normal right testicle and in the surrounding soft tissues, but there is no flow in the torted testes. Torsion. This was a 6-day with a history of testicular pain, 6-day history of testicular pain in a 31-year-old. This was the avascular testicle, and this was a peripheral hyperemia, which is reactive in this setting. So you can get this peripheral flow. In the older days, we used to do a nuclear scan to see this. And this is the same patient's nuclear scan using technetium. This is the photopenic defect of that torted right testis with peripheral hyperemia, and this was called the donut sign. Today we use ultrasound. We rather not radiate the testes, and with an ultrasound probe, you can explore a little bit wider field of view. Now, sometimes when the patient comes in with torsion, everything's so swollen that the clinician doesn't know what's what. So this is an example on ultrasound of that. This is longitudinal, is a big mess here, complex mass. What we're seeing is, this is the testes and this is the head of the epididymis superior to a necrotic testes. So it's an enlarged heterogeneous epididymis and peripheral hyperemia in a subacute torsion. Here again, left longitudinal, very heterogeneous testis, no central flow, a little bit of reactive hyperemia in subacute torsion. So there's zero flow in the testes. How about this 22-year-old with left testicular pain? Transverse, anterior, posterior, right, and left. Normal right testis, this is what soft tissue looks like. Compare it to the left. The left is very heterogeneous. On color Doppler, there is no flow. You have these echogenic islands of residual tissue, and this is what hemorrhagic infarction looks like. And there's a small reactive hydrocele. So this is a classic picture. I've seen multiple of these, a hemorrhagic infarction. Some of this could be clot. So the path was hemorrhagic infarct. So there are some pitfalls in diagnosis of torsion. You must use the same scale to examine the normal and abnormal testes. You want to be sure the scale is sensitive enough to detect flow in the normal testis. However, this was more of a problem in the older days when the technology wasn't so sensitive. Now we have very good and sensitive equipment. Another pitfall is if you have a less than 360-degree torsion, you might have a little flow. You might not have venous flow, which is the most collapsible, but you might have residual arterial flow. And the testes will look hypovascular, not avascular. This was a 9-year-old boy with left inguinal pain. This was his normal right side. Here's the color, there's flow. And on spectral, there is flow with flow in systole and diastole. This is the symptomatic side. There is much less flow on color Doppler. We did a spectral Doppler and you see flow, but there's no diastolic flow at all, meaning this is a high resistance or high impedance waveform, and this was a partial torsion. This is not common. What is a partial torsion? It depends on the duration and degree of the twist. Grayscale can be totally normal, but the key is to compare the spectral trace to the other side. Normally, you'll have low resistance flow in the testicle, meaning that you have some diastolic flow, and the flow will be high amplitude, as compared to the partial torsion, where you can get decreased or reversed diastolic flow. So here you have to compare the waveforms because there will be a little bit of flow on the symptomatic side. How about this case? This is a patient with acute right scrotal pain. This guy had acute right scrotal pain. This guy had acute left scrotal pain. So right scrotal pain, left scrotal pain. Let's look. This is the first young man who was 22. He had his right testes hurt at home. A lot of pain at home. He came into the emergency room and it totally resolved. So the testes was hyperemic compared to the left testes, which had flow. And why? This was a case of torsion detorsion. So he was at home, he had terrible pain, the testes was twisting. By the time he came in, it resolved, and you got the reactive hyperemia. Compared to our second patient, who had left scrotal pain compared to the normal vascularity in the right, his left scrotal pain persisted at home, came to the ER with the same pain. This was epididymoarchitis. Epididymoarchitis is much more common than a torsion detorsion. Before we leave torsion, let's talk about torsion of the testicular appendages, which these are the little excrescences that are embryologic remnants and hang off the testes or epididymis. This represents 5% of cases of acute scrotum. Where do they occur? 92% come off the upper testis and 7% off the epididymal head, but there are multiple. You can see this in a normal patient, asymptomatic patient, when this torsion is, when there is, hydrocele, where they're outlined by fluid. So the appendix testis usually lies on the superior half of the testis, and the appendix epididymis is attached to the head. So they're in similar locations. And the patient will usually point to the exact spot of maximum pain, which corresponds to the appendage, where there might be a blue dot due to the torted appendix. So what do we see? The testicle looks fine, but you'll have an avascular, hypo or hyperechoic mass between or adjacent to the upper testicle and epididymal head. There may be reactive surrounding hyperemia. There may be a reactive hydrocele and scrotal wall thickening. These two nonspecific. So this was a case, longitudinal ultrasound, superior, inferior. Here is the testicle, was fine with flow. The epididymis is superior here. It's not hyperemic, but between that epididymal head and perfused testicle, we have an avascular hypoechoic mass that corresponded directly to the patient's pain. This is a torted appendix, no surgery. He gets nonsteroidal anti-inflammatories. Another patient, longitudinal right testicle, which had flow. This is our colored Doppler box, epididymal head, mass between the two, corresponding to patient's pain, no flow in that appendage, He went home with non-steroidal anti-inflammatory drugs. Now, the most common thing I see with men from the emergency room is epididymitis. That comprises 75% of acute pathology post-puberty. Torsion's only 20%. Most of the infections are secondary to a lower urinary tract infection, such as E. coli, Pseudomonas, gonorrhea, or chlamydia. Other causes can be virus, syphilis, and tuberculosis. In children who get epididymitis, you have to look for an underlying congenital or acquired abnormality, but I have seen it in children with viral syndromes. How do the patients present? Pain, dysuria, swelling, fever, tenderness, and may have urethral discharge. So what does ultrasound look like? You have a large, heterogeneous, hypoechoic, hyperemic epididymis in epididymitis. And it could affect any part of the epididymis. And again, you can get a reactive hydrocele and scrotal wall thickening. So what percent of men with epididymitis have a concomitant orchitis? It's only 20%. What does the testicle look like? It could be focal or diffuse testicular enlargement, which is heterogeneous, hypoechoic, and hyperemic. Some examples. This is a transverse exam of the left testicle and had flow. I'm just not showing you great images of the testicle, but look at that tail of the epididymis that was inferior to the testicle on the lower aspect, next to the lower aspect of the testes. Usually the epididymal tail is tiny. This is big and hyperemic epididymitis, small reactive hydrocele. This is the epididymal body. Normally, the epididymal body should be less than 5 millimeters. This was close to 1 cm. It's heterogeneous, hypoechoic due to edema, hyperemic epididymitis of the body. This was a patient, transverse image. He had left testicular pain, right testicle, left testicle. That left testicle is much more hyperemic than the right testicle, and he had orchitis, and he also, on other images, had epididymitis. So when you have an infection, also look at the spermatocord. The spermatocord has normally, this is normal, some flow due to the vessels, but in the case of infection, it becomes hyperemic. And compare the two sides. So that's typical epididymitis. The epididymis gets big, heterogeneous, hypoechoic, and hyperemic. What are complications if it's not treated well? You can get a pyocele, which is a hydrocele with exudate. So instead of being a clear anechoic black hydrocele, the fluid will have septations and debris. So that's one. Number two, you can get an abscess of the scrotum, epididymis, or testicle. The worst complication is testicular infarction, and that's due to inflammation and edema leading to vascular occlusion. So this is an example of a patient with pain. He had right-sided pain and dysuria. So I see one structure posteriorly, and then one structure more anteriorly. So what's what here? Well, you have to put on color to help you. Color Doppler is key. So this structure posteriorly had flow, a lot of flow, and was the testicle. Centrally, you have a hypoechoic complex structure. So abscesses have peripheral flow. So this was a testicular abscess. And anteriorly, didn't have flow, and this was complex fluid, and this was a pyocele. So testicular abscess and pyocele. So this was a bad infection. This is another patient. He had left testicular pain. This is longitudinal of the testis. It was hyperemic orchitis, epididymal body, thick, hyperemic epididymitis, and surrounding the epididymis and the testes are a very complex fluid collection. Fluid is black with multiple septations, and this was epididymal orchitis with a multiloculated pyocele. This was another gentleman. He was older. This was his left testis, longitudinal, transverse, And this is more of the normal parenchyma. This is the scrotal wall. So what do you see in the mid and lower testes? This hypoechoic mass with these tiny little echogenic foci, some with ring down. And this was an unusual case of an air-containing or gas-containing testicular abscess. And here is the same patient. You can see the more normal parenchyma has infection with hyperemia, but this hypoechoic area with peripheral flow was the gas-containing abscess. How about this patient? This is his testis, and his epididymis was normal. Lateral to the testis was this thick-walled structure with a complex cystic structure with septation and peripheral hyperemia. So this was in the wall of the scrotum. It was lateral to the testes, peripheral hyperemia, abscess. Another patient to drive the point home, transverse anterior, posterior, right and left, normal left testis, right testis was hyperemic compared to the contralateral asymptomatic side. On grayscale, here's the testis with a little hydrocele. This is longitudinal. Superiors here, inferiors here. Inferior to the lower pole of the testis, we see a septated fluid-filled structure corresponding to the region of the epididymis tail with peripheral flow. And this was an epididymal tail abscess. Now, this is a dreaded complication. This is a 27-year-old who had a hyperemic testicle. 1 week later, no flow. He infarcted his whole testicle. So we want to treat as soon as possible. And this is an older image. This is a longitudinal of the right testicle, which was heterogeneous. And in the region of the epididymal head, you have all these echogenic foci with reverberation artifact. So what could this be? Air or gas? Look at the CT. So here is the scrotum, and you see around it gas, and you have infiltration of the adjacent perineum with gas. And what's this in this diabetic male? This is Fourniers gangrene. This is a rapidly progressive necrotizing perineal fasciitis with a high mortality. Typical, it's a diabetic. The mean age is 50 to 70. And usually the infection enters through the urethra, rectum, or subcutaneous tissues. The organisms are usually Klebsiella, Proteus, Streptococcus, Staphylococcus, Peptostreptococcus, and E. coli. This is a surgical emergency. The urologist has to do rapid surgical debridement, or the general surgeon actually with the urologist. Antibiotics stabilize hemodynamically because these patients could die quickly. So what do you see on ultrasound? The testes is usually normal. The scrotal wall is thickened with air or gas. CT, look for fascial thickening and fat stranding and soft tissue gas. The CT may show the cause, such as perianal abscess, incarcerated hernia, fistula, or it could just be idiopathic. So let's talk about scrotal trauma. You could have a hematocele, in which there's a hydrocele with blood. You could have a hematoma in the scrotal wall. You could have a hematoma in the testicle, and you could have a ruptured testicle. You can dislocate the testis into the inguinal canal. You can get a hematoma of the scrotal wall, of the testicle, and of the epididymis. So there's different places to look for hematoma. Rarely, you can have a post-traumatic torsion, and rarely, you can have a post-traumatic epididymitis. You could also have a bowel hernia. So there are a lot of different entities you can see. And the urologist has a very difficult time figuring out what's going on by clinical exam because everything is very swollen. The patient's in a lot of pain. So he's not sure what he's feeling and where exactly. So what do you look for in scrotal trauma? You could have a contusion in the testes or epididymis. And what does that look like? It's a heterogeneous abnormal texture of the structure. You have edema, you have bleeding. You can have focal or diffuse infarction. You can have a hematocele, which is a hydrocele with blood between the two layers of the tunica vaginalis. You can have a Waldorf hematoma. A hematocele goes around the testis. A Waldorf hematoma is more discrete. You only see a discrete fracture in 17%. So look for an irregular contour and loss of the testicular margins. So rupture is a surgical emergency and time is of the essence. A salvage rate of 80% if you intervene less than 72 hours and greater than 72 hours, the number goes down to 30%. Contusions are treated conservatively and hemorrhage can occur in the scrotum, the testes, or epididymis. Let's look at some images. This was a young man who had been playing football. You could see this is the testicle, very heterogeneous with hypo and hyperechogenic areas. And there is a complex hydrocele surrounding this testicle. That's the hematocele. And you have a fracture. This is the normal margin of the testicle on both sides, and here it gets interrupted. So this was a testicular fracture seen in 17%. You can also see hematomas. This is two different patients who had trauma, and you see complex collections with low-level echoes in this patient with septations. And in this patient, it was cystic and more solid appearing. If you put color Doppler on these hematomas, you would have no flow. This was another person. This was a 42-year-old veterinarian who was working as a veterinarian in a racetrack, I think Belmont Racetrack in Queens, New York, and he was kicked in the groin by a horse. So what do you have here? This is his testicle, which is pushed anteriorly by this large complex structure posteriorly. So let's look at this complex structure. It's very complex. You have echogenic and hypoechoic areas with debris. And this was a scrotal hematoma posterior to the testes, deviating the testicle anteriorly. So he was kicked in a groin by a horse. How about this 18-year-old young man playing soccer? Longitudinal right image. And we used a curved transducer here. Usually for the testes, we use a high-frequency linear. High-frequency linear is good for resolution, but the reason we needed a curved transducer to look at this testicle was you need a wider field of view, because this is the testis, and this was a large, complex, hypoechoic structure superiorly with septation and low-level echoes. And there's a little hydrocele. Let's look carefully at this structure, which had low-level echoes superior to the right testicle, and this was a scrotal hematoma. Let's switch gears for 1 second. If this was in an ovary in a woman with low-level echoes and some through transmission, what would you think of? Blood, like in an endometrioma. So in this young man, this collection had those homogeneous low-level echoes. That was blood. And then we switched to the linear transducer to look more carefully at the testicle. This was another person who was kicked by a horse. So you have to watch out for horses. So this man, this is his testicle, and he had this hypoechoic area and no flow in this part of the testis. So it was a contusion, a hematoma. When you look at the tunica albuginea, this is more normal testes. Here's that white line, and then you kind of lose it. So there's focal disruption of the tunica albuginea. This is the scrotal contusion, and this is the complex hydrocele. So look very carefully in multiple views to see if you see discontinuity of the tunica albuginea, which would be worrisome for fracture. which would be a fracture or rupture. This is more obvious. This is a 24-year-old who is kicked playing basketball. Sagittal and transverse images. Hydrocele superiorly. Here's a normal testicle. This is the tunica albuginea, totally broken, and you have extrusion of the testicular parenchyma outside of the testicular contour. So this is a big disruption. You're missing the tunica albuginea and sagittal, transverse. Here's the tunica albuginea, the nice contour of the testicle, extruded tissue here. And this was another case of testicular rupture. Let's talk about inguinal hernias. What is an inguinal hernia? It's protrusion of the intra-abdominal contents through a patent processus vaginalis. So what's a processus vaginalis? It's an outpouching of the peritoneum through the internal inguinal ring, which normally closes following testicular descent. So this is an example of an obliterated, this is what the processus vaginalis usually does. It gets obliterated in early life. Here is a bowel loop. Here's the testicle and the tunica vaginalis. So what happens if this processus vaginalis is not obliterated? This was a patient who had left testicular pain and a bulge. A longitudinal exam, here's the left testicle, upper pole, and we saw this nondescript hypoechoic structure superior to the testes with little lines, and this is what intra-abdominal fat could look like. We traced this up to the lower abdomen, and this was omental fat. So if you can't see it, remember, have the patient stand or do a Valsalva. Corresponding CAT scan, this was a fatty inguinal hernia. Sometimes you could push it back, and my techs sometimes tell me whether they can or not. So in conclusion, scrotal ultrasound and color Doppler imaging are sensitive and specific in distinguishing between acute inflammation and torsion, but beware of pitfalls. Remember the pitfalls, and scrotal ultrasound and color Doppler are helpful in the setting of trauma. Let's review with a couple of questions. And what is the most common cause of acute scrotal pain in an adult? Is it trauma? Is it torsion, intravaginal or extravaginal torsion? Is it epididymitis, or is it torsion of an appendage? Think about it for a minute. It's epididymitis, treated by antibiotics, treated by emergency surgery, torsion of appendage, treated by non-steroidal anti-inflammatory drugs. Remember, intravaginal torsion is associated with the Bell-Clapper deformity. It's mostly in puberty, younger men. Extravaginal torsion, much, much less common in neonates and in utero. What is the best diagnosis? This patient had testicular pain. Notice there's no flow, and this could be a seminoma. What's the best diagnosis? Seminoma, GC orchitis, gonorrhea, atrophy, hemorrhagic infarct, or fracture. Think about this for a minute. This is color Doppler showing no flow in this heterogeneous testicle, and this was a hemorrhagic infarct. A seminoma, well, I'm not going into tumors, is usually a hypoechoic vascular mass, very hypoechoic discrete mass. If you had orchitis, you'd have increased flow. Fracture, you'd have disruption of the tunica albuginea. Atrophy, the testicle would be small, and this is a hemorrhagic infarct. Last question, which statement is false regarding Fourniers gangrene? It is more common in diabetics. It is a perineal fasciitis. you're usually seeing gas. The testis is usually involved. E, it is a surgical emergency. So think about this for 2 minutes, for a minute. What's false? The testis is usually involved. What is true? It is more common in diabetic males. It is a perineal fasciitis. You often see gas. The testis is not involved, and it is a surgical emergency. I thank you for your kind attention, and it was a pleasure to speak to you all. And if you want to reach me, this is my email. And thank you for your kind attention.
Thank you so much, Dr. Stein, for this wonderful lecture. It was great. Thank you so much. And as you see here in the chat, a lot of the attendees are participating and trying to answer the question that you are putting there. So thank you so much for.
Oh, okay. Okay.
Yeah. Thank you so much.
I see there's some questions. Should I go to the questions?
Yeah, we will go through the questions.
Okay.
Yes. So there is a question from Frederick. He asks, aside the history, can ultrasound confidently differentiate orchitis from a detours testis with reactive hyperemia?
It's all history. If you have epididymitis, the testis is going to hurt for a while. It's good whether you're home or you come into the ER. With torsion, detorsion, say they had pain at home, go to the ER, everything is better when you get there, no pain. So it's all history. And yet, and also frequency. You know, torsion, detorsion is very rare, and epididymitis and orchitis is common. So it's history.
Thank you. There's a question also from Dr. Nazrina, and excuse me if I'm pronouncing wrong, but she said, excellent lecture. Well, she was a bit confused on spermatic cord anatomy on ultrasound, and she asked, can we see it in normal setting or until there is some pathology?
You can see it, sometimes you'll see like a few vessels, but you're not going to see the nerves and the you mainly see a few vessels, and it's superior, and I could see it move. And it's hard to see. I sometimes have a hard time seeing it also. If you're worried about pathology, compare the sides. You know, we always have another side, but it's just like this wispy area with a little bit of vessels superior to the testicle. That's normal.
Thank you. Another question, do you quantify hydrocele? And if there is a normal minimal amount bilaterally, and how much?
Okay, we don't quantify it. It's just subjective. It really is. I mean, my texts sometimes measure it and I'll give a number, but I do it subjectively. Yes, there is a normal amount of fluid. It's just like a little bit, and it's also very subjective. It's where physiologic fluid in a tiny hydrocele begins. It's a gray zone. When you read a lot of these, it's just subjective. Like certain things are very subjective. And this is one of them. I find another thing that's subjective if you go to the liver. If you have a very fatty liver, it's kind of obvious. But if you have maybe fatty liver, mild fatty liver, it's more subjective. And this is one of the things.
Thank you, doctor. Another question, do you need to measure epididymis head, body, and tail? Will the management change depending on which part specially is measured in epididymitis?
My texts measure the epididymal body and head, all cases, in trans and longitudinal. The management doesn't change in epididymitis, no matter what area is infected. They'll give them antibiotics.
That's great. In scrotal trauma, is it possible to differentiate hydrocele from hematocele, or will just based on the history alone to be able to say it is likely hematocele?
It's also the ultrasound. It's in the right clinical scenario, but if you have a complex hydrocele, meaning septations and a lot of debris in the setting of trauma, I would worry about a hematocele. A regular hydrocele is usually clear. If you have a chronic hydrocele, though, I've seen some septations, but it's a lot history and complexity.
Can bell clapper's deformity be seen on ultrasound? If so, what is it? And what's its sonographic appearance?
Um, can I see the bell clapper deformity? Not really, but with torsion, I can see, but not commonly, a world appearance of the spermatocord. So that would be a sign of torsion, but I really don't see that very often. You can look in the books, it looks like a whirly thing superior to the testicle, but I don't see it often at all.
Question from Inerco. She said the microlithiasis testicle is considered malignant.
No, it's not considered malignant. It used to be thought of as a warning sign for the development in the future of malignancy, especially seminomas. But recent studies have shown that microlithiasis, yes, there is a small risk of the development of a future malignancy, but it's much, much less than we initially thought. So it's up to the urologist. My husband's a urologist, so I speak to him and his friends. Do they follow microlithiasis? No, because it's not uncommon. I mean, I see it probably once a week, and when I do a lot of scrotal ultrasounds, but it's a weak association for malignancy, I would say, weak. And you can have an increased incidence of microlithiasis in like certain syndromes, like Down syndrome, they have a higher incidence, but it's a weak association with malignancy.
And Dr. Sorigiani, how a spermatocele appear on ultrasound?
A spermatocele looks the same as an epididymal cyst. They're both in the epididymis, more in the head, and a spermatocele usually has internal echoes compared to the cyst, but they can look exactly the same, and it doesn't measure what you call it. It's either an epididymal cyst or spermatocele. Much more in the head. They're usually small. They can be multiple. And they have a higher incidence in men who have dilated reedy testes. Older gentlemen can get dilated reedy testes with an ipsilateral spermatocele. But spermatoceles are common, usually asymptomatic.
From Dr. Ahmed, does TB orchitis differ from other bacterial orchitis?
That's a very good question, and it's a hard question because I haven't seen much TB orchitis. But what you can see is an orchitis, maybe with some calcifications, that's kind of ill-defined, heterogeneous areas, and it can affect the epididymis and the testicle. You might have adenopathy, but it's history also.
Question, according to your expertise, doctor, do you perform special maneuvers in infants to stimulate Valsalva maneuver?
Well, I don't do pediatric radiology. That's like a separate room in our department. But I don't think you can make an infant do a Valsalva maneuver. Maybe if they cry, but I can't answer this question. I don't think they do special maneuvers, but I'm not 100% sure.
Thank you. Another question, doctor. If there is any grading systems for varicoceles in terms of severity, or it is just subjective?
I do it subjective, and I also measure the largest vein AP, and I give that size to the urologist. That's what they want. But it is subjective, and I always think I wish I had more of a non-subjective criteria. So I give them what I can. It's easy when it's large, and it's easy when it's small, and in the between, it's not so easy. And they'll correlate it with physical exam.
Yes, yes, I see. Okay, our last question, doctor. If there is somebody that you suspect has torsion, detorsion, Do you write that in the report that you suspect torsion, detorsion, and how can you deal with that medical legally?
Well, I'll tell you, I just had a case, and I'm going to look up the path today, that I think he could have had torsion, detorsion, or partial torsion. And I put it down because it was very interesting. I had a very astute technologist who I trust implicitly. The testicle was very hypovascular, and sometimes there was flow, and a few minutes later, there was no flow. So what they did is call the urologist, and they have to examine him if they're worried they're going to operate. But it's a hard diagnosis. I mean, if I see that once every 3 months, that's a lot.
Yeah, I see. Last question, doctor. We got another question. Dr. Ahmed asked, what are the differentials of painless scrotal masses?
Oh, painless scrotal masses. I would think, the first thing you have to worry about is a testicular tumor. Okay, and it's usually painless. So testicular tumors come in mainly germ cell tumors, about 96%. Most of them are seminoma, and they're homogeneous hypoechoic masses. Then you have non-seminomatous germ cell tumor, and they are like embryonal cell, choriocarcinoma, yolk sac, etc. They're hypoechoic, plus they can have calcifications, plus they can have cystic areas, as opposed to the homogeneous hypoechoic seminoma. Then there's a small percent have sex cord, like stromal tumors, like Leydig cell, really rare. So when I see a painless scrotal mass, I have to worry about that. I mean, it could be a big varicocele the doctor is feeling. I mean, a big spermatocele that the physician is feeling, a hernia. So you have to worry about tumor. Tumor is not a good thing. Going back to the tuberculous orchitis, I'm not an expert on that. So I tell you, look that one up if I left anything out with that.
Yeah. Thank you so much, doctor, for this great lecture. I'm sorry, we got another question. If you have time, can you take this question? Last question.
Yes, of course.
Okay. How to differentiate focal infarct from testicular tumor?
Well, most testicular tumors, the vast majority, have flow. They really have flow in everyone I've seen, or 90% of the ones I see, especially seminoma, it's very vascular. Versus what? A focal infarct? A focal infarct usually has a history of trauma, or maybe an infection, or maybe a remote history of infection or inflammation, or an undescended testis. So it's a lot history. But, with the tumor, they're going to check the tumor markers also. I mean, it's kind of more obvious when it comes to it's hard mass on physical exam, it's ill-defined, it has flow, different history.
That's great, Dr. Stephen. Thank you so much for this wonderful lecture and for answering those questions. To see attendees are very excited and they are thanking you in the chat box.
Oh, okay. It's my pleasure to talk to all of you, and an honor. And I wish you all the best and all good luck, and keep studying and keep reading.
Thank you, Doctor.
Bye. Bye, you guys.
Bye. Have a good day.